So today we're going to discuss about MRCP paces respiratory station, and I'm going to talk a bit about case of lobectomy. So remember this case is actually quite simple because once you do the inspection, the scar will be obvious, and you already have an idea that the patient has either some procedure, some surgery in the lungs, which could be either lobectomy, it can be pneumonectomy, it can be wedge resection. So remember that as this case is quite simple, the diagnosis is obvious, it has to be done um, very nicely in order to get good marks in your respiratory station. So once you enter the room, you're going to greet the patient, greet the examiner, and then you're going to take consent from the patient for the examination. So we'll start doing by inspection. So just stand at the foot end of the bed and do the inspection. So you look at the chest wall, surgical scars indicating the previous lobectomy or any procedure, you don't know whether it is lobectomy, is typically located in the lateral or posterior aspect of the chest. And here I have mentioned you can see this something like this scars, which you can see on the laterally and posteriorly. On the front will be like this. You want to, while you are doing the inspection, just observe the any respiratory rate, whether it is normal or slightly increased. The patient might have adopted to reduce lung capacity, and also look for any cyanosis for the peripheral cyanosis as well as central cyanosis. So should not be any cyanosis unless there are any complications. So once you had completed your inspection, you will proceed with palpation. Specifically look for trachea. So trachea deviation absent. If deviation might occur in some cases with large tumors or pleural effusion. And remember that if you have a pneumonectomy, then it's possible that trachea may be deviated. If scar is obvious and trachea is deviated, then you must think about the pneumonectomy. Going to do the chest expansion will be diminished on the effective side, so it will be leading to some asymmetry compared to the other side. Sorry for that one. Then you'll move on and do the percussion. So the percussion will be resonant over the area of lobectomy, and there is hyporesonance due to increased air content in the remaining lung tissues. And then you'll move on and do the auscultation. So breath sound will be reduced or absent over the area of lobectomy, indicating diminished air movement, and decreased vocal resonance over the affected area, confirming the absence of normal lung tissues. So, but remember that once you are doing your inspection and your percussion and auscultation, think about the differential diagnosis, that why the patient had this procedure. So there are only few things due to which lung surgery is done. Lung cancer is one of the cause. So look for any scars in the thoracic region indicating a previous lobectomy. So in the case of lung cancer, remember the surgical scar might be larger because due to the need of extensive tissue removal. Another important thing is look for any cachexia. So patient with advanced lung cancer might appear cachectic and malnourished due to systemic effect of the disease. Tuberculosis, well, check for scars indicating the previous lobectomy. In case of tuberculosis, scarring might be observed in other areas of chest due to chronic inflammatory process. Bronchiectasis. Now examine for scars indicating the previous lobectomy. Bronchiectasis, there might be additional signs such as digital clubbing. And you have this scar. Sometimes there can be wedge resection in bronchitis. If there's localized bronchitis, there may be wedge resection. So what are the indications for lobectomy? Lung cancer, non-small cell lung cancer. Lobectomy is often the preferred treatment for early stages non-small cell lung carcinoma when the tumor is confined to one lobe and has not spread to nearby lymph nodes. Small cell lung cancer, well, in certain cases of limited stage small cell lung cancer, lobectomy might be performed if the tumor is confined to a single lobe and the patient is in good health. But normally the small cell lung cancers are usually when they present is already has metastasized. Another indications are lung infections. For lobectomy, tuberculosis, severe case of tuberculosis can lead to extensive lung damage and lobectomy might be necessary to remove the affected lobe. Bronchiectasis, already discussed. This chronic condition is characterized by damaged and widened airways, so might require lobectomy if a specific lobe is significantly affected and conservative treatments are ineffective. Another indication is benign lung tumors like pulmonary nodules, suspicious or growing nodules that cannot be ruled out as cancer. They might necessitate lobectomy for definitive diagnosis and treatment, and hematomas. So benign tumors composed of lung tissue element that might require removal if they cause symptoms or complications. Another indication is lung trauma if they got penetrating injuries. So severe injuries to the lung due to stabbing or gunshot wound might require lobectomy to control bleeding or remove the damaged tissues. Any blunt trauma, severe blunt force trauma to the chest can lead to significant lung injury, so potentially requiring the surgical intervention. Fungal infections like aspergilloma can form balls of fungus in the lung cavities. So if conservative treatment fails, surgery might be necessary, potentially involving the lobectomy. Congenital lung abnormalities like bronchopulmonary sequestration. In this portion of the lung does not communicate with the normal bronchial tree, so lobectomy might be performed to remove the sequestered lung tissues. And if there are any complications of previous surgeries, post-surgical complications, such as infections, necrosis, or bronchopleural fistula might necessitate a lobectomy for definitive treatment. So these are all the indications for the lobectomy. So once you have done your examination, then you're going to do the case presentation. So here is one of the example for the case presentation. So you're going to mention the clinical examination findings first. So on inspection, Mr. Anderson appears comfortable but slightly dyspneic at rest. He has a well-healed surgical scar in the right upper thoracic region. On examination of the respiratory system, chest expansion is reduced on the right side. Breath sound decreased over the right upper thoracic area. Percussion note is hyperresonance over the right upper thoracic area, and vocal resonance is decreased over the right upper thorax. So mention all the positive findings. Then you not stop here in your presentation and you talk a bit about the differential diagnosis. So considering Mr. Anderson history and examination finding, the differential diagnosis includes post-lobectomy complications such as bronchopleural fistula or pleural effusion, pneumonia, infection can occur in the remaining lung tissue, tumor recurrence, possibility of cancer recurrence at the surgical site, chronic atelectasis due to reduced lung volume post-lobectomy. So here I put the differential diagnosis post-lobectomy, actually complications because patient has some dyspnea and is a bit cachectic. Then you're going to propose some investigations in your presentation. I would like to do chest X-ray to assess the lung expansion and rule out pleural effusion, CT scan of the chest, which give us idea about the lung parenchyma and identify any abdominal masses of failure, sputum cultures to check for infection, and tumor markers to assess for cancer recurrence. And then you're going to continue with your management plan. Empirical antibiotics, start the broad spectrum antibiotics while awaiting the culture results. If there is any element of effusion, then chest tube insertion. Thoracic surgical consultation for assessment of possible bronchopleural fistula or tumor recurrence. Pain management, so address the chest pain with appropriate analgesic, and oncology consultation in selected cases if cancer recurrence is confirmed. So we want to refer for further oncological management, including chemotherapy or targeted therapies. So this is all about the presentation. So remember, be systematic and follow these headings. Just tell about your clinical examination findings first, then move on to your differential diagnosis, proposed investigations, and finally your management plan. So some of the questions which could be asked by the examiner: what are the common complications after lobectomy and how would you manage them? So common complications after lobectomy, these involve pneumothorax, pleural effusion, infection, bronchopleural fistula, and atelectasis. Management involves, depending on what complications have, chest tube incision for pneumothorax or pleural effusion, appropriate antibiotics for infection, possible surgical repair for bronchopleural fistula, and lung expansion techniques for atelectasis. Another question which the examiner may ask: how do you assess the adequacy of lung function in a post-lobectomy patient? Lung function in a post-lobectomy patient can be assessed through pulmonary function test, including the spirometry and lung volume, and these tests measures lung capacity, airflow, and gas exchange. In addition to this, imaging studies such as chest X-ray or CT scan can provide information about the remaining lung tissues and possible complications. What are the long-term implications of lobectomy on the patient quality of life? So lobectomy actually lead to reduced lung capacity, affecting exercise tolerance and overall quality of life. Patient may experience dyspnea, fatigue, and limitation in physical activities. Rehabilitation programs and support groups play a critical role in helping patients adapt to these changes and improve their quality of life. How do you counsel a patient before lobectomy surgery regarding the procedure risks and recovery? So one of the model answer: before surgery, I will provide detailed information about the lobectomy procedure, potential risks such as bleeding, infection, or anesthesia complications, expected recovery time, and post-op care. It's essential to address any concerns the patient may have and involve them in the decision-making process. Additionally, discussing rehabilitation and support services available post-surgery is crucial for the patient emotional and physical well-being. And finally, examiner may ask, can you explain the potential complications of post-lobectomy pain and how will you manage them? So post-lobectomy pain can result from surgical incisions. It can be because of nerve injury or tissue inflammation. Complications may include chronic pain syndromes. Management involves a multimodal approach, including pain medications, physical therapy, nerve blocks, and in some cases referral to pain management specialists. Addressing psychological aspect of pain and providing adequate support are also important components of pain management. So, my dear doctors, this is all about a case of lobectomy. Normally, when you have this scar, think about all the differential diagnoses. It can be lobectomy, it can be pneumonectomy, it can be wedge resection. So depending on, once you do your examination, then you can refine your diagnosis and your examination will lead you to a top diagnosis. As I mentioned previously, that if the patient have pneumonectomy, first of all, just look at the position of the trachea. So trachea will be deviated. It will be deviated towards the surgery site. And the other thing is, in case of lobectomy, there will be an localized area of dullness. However, the remaining areas, lung will be resident. In case of pneumonectomy, there will be dullness throughout the lung field on that site. So hopefully this presentation will help you in your respiratory station. Thank you very much, and I'll see you in my next presentation.